the Metacrats, and because I studied Latin in school for 7 years, let me tell you a little bit about this title. Crats actually, what's the crat, okay? If you look at aristocrat, autocrat, democrat, bureaucrat, it comes from kratia, which is Latin for to rule, okay? So that, the Metacrats are ruling our healthcare, and they replaced the aristocrats of 1609. This past weekend, former president of APS Lehigh was on John Stossel. How many people saw the video? Okay. It's on medibid.info if you want to see it. There's a YouTube clip. It's about 9 or 10 minutes. She did a great job promoting apps, and we need to get out there and do, Jane's on all the time promoting apps. We need to be more vocal. Richard Ammerling and Tamsin and everybody else. We need to keep doing that. Lee spoke about the 3 C's. Cash, catastrophic insurance, and charity. So when we talk about the solutions, therein lies, many of them. We've also talked, of course, as Jane says, the patient-physician relationship. I want to start this session by talking about catastrophic insurance. The thing that we call health care or health plans or health insurance, that's not really insurance. We know that. That's prepaid health care. It attempts to cover unsystematic risk, which is impossible. Okay? Unsystematic risk is simply the redistribution of wealth, where the winners and losers are known in advance, and you can't do that because it's a perverse incentive. Insurance, true insurance, does a really good job at covering systematic risk. When we buy car insurance, house insurance, life insurance, disability, critical, we get the policy home and we file it away and we hope that we never have to use it, but we know it's there if we need it, okay? And usually we can't influence where a claim will happen. I recently consulted for a family physician. They have 2 doctors, 1 full-time, 1 part-time PA. Total revenues are $2.86 million per year. Of that, the 2 physicians combined have an income of $370,000. That's less than 13% of every dollar spent. Now, we know why it is. It's the third-party payers and all the burdensome regulations and compliance and billing and rebilling. So if you take it back one step further with the medical loss ratio, which says that 80% out of every dollar has to be spent on medical care. So if you pay Blue Cross $100, they'll pay $80 to the doctor's office. Of that 80, 12.9% goes to the physician. That's $10.32 out of $100. That's going to the doctors, okay? So that's our health plans, our third-party payers. If we get a true catastrophic plan, and some examples of good ones, of course, the HSA plans with a $5,000 or $10,000 deductible, they're good as long as what you do underneath that $10,000 is the right thing, and I'll talk about that in a minute. Policies like critical illness insurance, okay? And we had a webinar on that last month. It was invented by Dr. Marius Bernard, a heart surgeon. And it pays a lump sum between $50,000 and $1 million in the event of diagnosis of one of 21 illnesses. You can't influence that. That's true insurance, okay? That's a good one. Accident insurance is also good. Laceration, concussion, contusion, it pays, based on the care. It's not the prepaid care where they're telling you what to get. Now, as I said earlier, when they bundle all this stuff into the payment system, we're paying for all kinds of things that we don't want. So, that 80% that's paying out medical care, that's not necessarily the medical care that we want. That's all of the stuff, okay? So if we get a plan with a $10,000 deductible, how many people have heard of an HRA, a health reimbursement arrangement? Anybody heard? Okay. And of course, I think probably most of you have heard of an HSA, right? Okay. If you combine the two, it actually works really well. You have a plan with a $5,000 single and $10,000 family deductible. Your first $1,200 will be covered by an HSA. So the individual patient is paying themselves because we all spend our own money more wisely. If that $1,200 threshold is exceeded, the next $3,800 is covered by an HRA, which is employer's money. Now, HRA money is very efficient because instead of being an 80-cent dollar, it's a 100-cent dollar. Instead of paying for things like abortions, contraceptions, wigs for cancer patients, et cetera, the employer defines what it's paid for. So you have very efficient dollars being spent, both in your HSA and your HRA. So the first $5,000 for single people, $10,000 for family, are efficiently spent pre-tax dollars. And then after that, you've got your $5,000 or $10,000 deductible, which is still pretty efficient. So those kinds of plans can be very, very efficient. So insurance in itself is not a bad thing if we use it to cover systematic risk, where the winners and losers are not known in advance. The other good advantage of that, back in '86, they had something called small group reform. Has anybody ever heard of small group reform? Grace Marie probably has. Small group reform. What it did is it made employer health insurance guaranteed issue in every state. The problem with it, one of the many problems with it, is it pools right down to the first dollar. Okay, so right to that first dollar coverage, you're paying for your neighbors and the business down the road, and you know, you're paying for everybody. It is you know, socialism. It is crony socialism. And it does attempt to cover unsystematic risk. But if we go up to that $10,000 threshold, anybody that spends $5,000 or $10,000 is genuinely sick. They're not abusing it, okay? They're not getting what's covered because they're entitled to it. So that's one way that we can really harness true insurance. And that's one of the solutions. Our next three speakers are going to talk about their different experiences in charity. And that brings me to the last part of tonight, and then we'll open it up for questions before our closing comments. And I'll go through this part really quick. The last of the three C's is cash, and the efficiency of cash. There's no doubt that cash is efficient. How many people remember the Francisco de Cunha money speech? You remember that? Okay. I wish I could play it. It's classic. I haven't reread it for a while, but it's classic. We did a survey a while ago, probably about 2.5 years, and we asked physicians to tell us about their patients on Medicare, Medicaid, private insurance, and cash. How many patients do you have in each category? How many visits per patient in each category? And how much revenue in each category? No surprise, Medicare patients had the highest number of patient visits per year, per patient, no surprise. What was surprising is the second highest was cash pay patients. Second highest number of visits per year. And they paid the most. They were the most profitable for doctors. So we had a focus group with patients, and we said, okay, if you're paying cash, you're paying a lot more than a $20 copay. How come you go back more often? And what they told us is, when I'm paying a $20 copay, I get 6 minutes, I get no eye contact, I leave with a prescription. When I'm paying cash, my doctor's Marcus Welby. I get eye contact, he knows my pet's name, he knows my daughter's name, and I leave educated and empowered, not medicated. Okay? And that means a lot. And we have studied the cost of care. We have studied how much it reduces the cost of care. One patient, very quick example, 29-year-old big guy, 6'4", 250 pounds or so. He wasn't hugely obese, but he was a big guy. He was overweight, there's no question. He went to the physician, 6-minute visit. Here's your, hypertensive. Here's your prescription. It's going to be $86, a month for the rest of your life. Okay, $1,000, $50,000. This is going to cost you $50,000 over the rest of your life. That's if there's no inflation. Okay, and he called us up and he says, I don't get it. Is this how it's supposed to work? So I called a friend of mine, physician in California, and I said, listen, I'm not a doctor. It just seems to me that the first question should have been, what's your diet? What's your exercise like? What's your stress at home? Let's look at some of those things. And so anyway, she met with him. She did a second opinion, and that's exactly what she did. She said, go join the gym, cut out the beer, okay, cut out the carbs, come back and see me in 3 months. 3 months later, he was down to 217 pounds, no more hypertension. Okay, so it was an extra $100 for another doctor's visit, but it saved $50,000. So that's the power of cash. You won't find that with a third-party payer because that's not covered. Paying cash also has a lot of other effects. Dignity. The dignity of being able to reach in your own wallet and peel out that money or write that check or pull out that credit card instead of saying, Blue Cross is paying, okay? The dignity that it restores to give that $15, for those that can, to give that $15. It restores dignity. There's no downcoding. Yes, it was a level 4. No, it was not a level 3. You don't even need to discuss that because AR is a liability against a practice. Because in the event of a lawsuit, and we all know that how much of our accounts receivable do we collect? 60% if we're lucky, right? Okay, those that bill third-party payers. So having a huge amount on your accounts receivable, if you're sued, they can attach those accounts receivable, even though chances are you'll never collect 100%. With cash, that doesn't happen. The reduction in overhead, that practice I was talking about earlier, 24 full-time employees for 2 doctors. I said, is this an accounting office where 2 physicians work? This is not the way medicine should be practiced. Cash gets over that. Most importantly, you decide the kind of care you want, okay? You don't get told what's covered or what you're permitted to get. You decide what you want and you purchase it. Maybe you want prolotherapy. Maybe you want HIFU for prostate cancer. Maybe you want hyperthermia instead of chemo. You have choices with cash that you don't have with a third-party payer. And patients appreciate and understand that. We just need to tell them that. We just need to explain that. At MediBid, last year we saved patients over $1 million. And we compare that with the Chargemaster prices. Our prices, we have a surgery center, Somerset Orthopedics, 6.1 miles down the road, or a $40 cab ride in New Jersey. Just because I don't know how to say Long Island. If I'd said that, they'd say, oh, you're from here. Okay, it would have been $20. But anyway, they do a full knee replacement for $12,000. Okay, the insurance discounted price according to Healthcare Blue Book is $22,900. Chargemaster price is $50 to $60,000. Okay, so the cash price is much more fair. Because there's none of those hassles. We're getting MRIs done in Nashville for $410 with a 1.5 Tesla. Okay, there's nothing wrong with that. You go to emergency and Blue Cross pays, it's $5,000. We're talking to employer groups, large employer groups, and we're setting up plans where within the Blue Cross network in the city of Nashville, a colonoscopy ranges from $850 to $3,500. There's no transparency. You don't know which one you're getting until 7 weeks after when you get your EOB. Okay? We've set up a plan where we look at the median price, which was $1,300, and the employer says, this is what we're paying, $1,300. If you want to go to the guy for $2,000, you pay the extra $700. We don't have to change the deductibles or anything. Now, anybody who's ever been sent on a business trip for their employer, if you check into the Ritz-Carlton, are they going to pay? No. So why should an employer pay the $3,500? So that's how we set it up now. If they use MediBid, and our average price for colonoscopy is about $650, if they get the MediBid price, that's half of the median. They've saved $650. The employee saves $325. The plan saves $325. Okay? It's common sense things. It's using cash. It's allowing physicians the dignity and respect of setting their own prices. That's what works. Those are the solutions that work. The health insurance companies want you to think that they have more negotiating power. No. They don't. They don't. What you have when you pay cash is you have the power to walk out the door and say, no thanks. I'll go down the road. You don't have that with Blue Cross. You don't have the power of no. You go where they send you. So cash controls the conversation. It gives you what you want or what you need, not what you're told you can get. Now, we're going to have a short period for questions. We're going to shorten it down to 10 minutes.